Gentlemen, I'm really excited to be here for this debate, and I thank the organizers, especially Dr. Kamini Rao, to invite me for this interesting debate. So I'll be speaking for social egg freezing as preventive medicine. As she explained, my background is in reproductive biology, a little bit. So I basically, this is my team. Since the last 26 years they have been working, and I joined them 6 years ago. My basic background is I used to work with Dr. Teresa Woodruff in fertility preservation unit for cancer patients in Chicago. And then after that, I've come to Mumbai and work with the IVF centers and the oocyte bank. So let's begin with egg freezing. Technically called fertility preservation. It's a technique where you freeze the oocytes. We have talked a lot about it in the morning sessions. So I'll directly move to the concepts, why it is required. The medical indications currently are, for example, cancer, where the gonadotoxic therapy is required for the patients. Okay, I'll just keep talking till they get the PPT together. So cancer is the first indication, and that's why the fertility preservation techniques was started to be used. I'll move back. So the gonadotoxic therapy, as you know, it causes premature menopause in the patients, as well as total ovaries can be destroyed. There are various surgical ways to take care of this, but one of the main indications is you need oocyte freezing as a backup during these cases. In cases of PCO, severe PCO and severe endometriosis, where the ovary is involved in endometriosis especially, you should, it is indicated that oocyte freezing be done at a relatively young age, so that in later cases where ovary is involved and the oocyte quality goes down, this patient has a chance of having a normal progeny. The point that we are talking about, the social egg freezing, the way you call it, the personal and social reasons are now coming as indications for doing freezing. There are two types. There is an intentional delay, where career and education comes to the forefront at the same time that reproductive options come for women. Women have a relatively less period of time to get everything done, their career, education, as well as having a baby. So it could be an intentional delay, or it could be an unintentional delay that she wants to have children, but she lacks a suitable partner at that particular point of time. So we'll be discussing these indications especially for social egg freezing. The definition of fertility preservation, we call it in 2014, Dr. Stoop called it age banking, anticipated gamete exhaustion, basically age-related fertility decline. Here, as we know, the oocyte number goes down rapidly after the age of 30. And ASRM, which is American Society of Reproductive Medicine, the opinion is once a woman is older than 35, you need to immediately start treatment within 6 months if she is not able to conceive. We believe, or at least I believe, that social freezing is just an extension of this opinion. Since you have women over 35 that require treatment within 6 months of not being able to conceive, it makes much more sense that these women are also offered the possibility of freezing if they are not taking care of their reproductive options at that particular point of time. So we have discussed the technology in detail. I don't want to get into how you vitrify, although that's one of my main topics in other conferences. I would be specifically focusing on how far we have come in freezing from 2004 till now. Actually, vitrification is not a new technology, but it has come to the forefront since 2006 specifically. It started mainly in the US, and then it started trickling down to UK and now to India. So what happened was slow freezing was typically used before, but the survival rates were very low and they were not reliable. Now vitrification has improved it to 90% or around. I would not claim very high survival rates because it depends on the hands who's doing vitrification. And automation is something that is required in this place, but right now it's completely manual. The live birth rates as reported in 2015, so I've used pretty recent papers, they are reporting live birth rates are similar for fresh and frozen eggs. And that has been my experience in working with frozen oocytes. But I have to clarify, I have been working specifically with donor oocytes more rather than with oocytes of patients or women, reproductive age women who need social egg freezing. So I would be extrapolating my information from donor oocytes. The average live birth rate has increased from 4% to around 10% from 2006 to now in 2013, 2014. It was reported somewhere around 10%. These are interesting statistics. These I've taken from RCTs, multiple randomized control trials. The last 2 points, it's most cost effective when it is done at the age of 37 years. Why? Because when you're talking about social egg freezing, the cost is a very important factor. And the highest probability of live birth. So there are 2 points you have to consider. The first is, what is her possibility of having a baby if she undertakes a procedure like egg freezing, which is highly technologically advanced. She needs to enter a hospital for that purpose, and she has to undergo a minor surgical procedure for that. So the highest probability is under the age of 34, but the cost effectiveness is at the age of 37, and it is recommended for women below the age of 39, never recommended above the age of 39. The problem is, right now, most of the women that come for freezing are above 40, because that's when they start realizing that maybe they're exhausting their gamete potential. But all the experts, fertility specialists have to understand that above the age of 40, the results are very, very poor for egg freezing. So you need to provide it you need to indicate it only for patients below 39, 38 years of age. What drives the need? Social egg freezing obviously has come to the fore only when people started demanding it, because the technology was available, the IVF centers were available. So fertile women started coming in and saying that I'm not going to have a baby for the next 3-4 years. Would you conduct this procedure for me? What drove this? So the media thinks it was driven by the career ambitions of the women. That's not the whole truth. It's actually driven by the fact that women don't have a suitable partner. Now, this is not what I think. This is what the Estate Task Force thinks. That was their 2012 survey that was done in more than 1 lakh women. And they say that it's the lack of suitable partner that is driving them to go for egg freezing, which is an unintentional delay. They're not intentionally delaying their reproductive options. It's because they don't have a partner that they are not able to have a baby. Which is why the Estate Task Force has given the recommendation that for age-related decline, they recommend to go for oocyte freezing. In 2005, they had a task force in 2005 as well of ethics and law, where they were not recommending it. But in 2012, they changed their mind, dependent on the RCTs that came to the fore. The second thing that drives need, and where the maximum debate will happen, is the lack of societal change. The flexible work environment, however, it is shown in the media, a few companies maybe, but it's not there in the private or the public sector, yes, but the private sector, it's not available. Better leave policies, work environments are not available for these women. So yes, there is a women population that are causing a delay in their childbearing, because they can't do everything together. So they are facing a lot of pressure to do their career, their education, as well as having a baby together. So this gives them a little bit of breathing space. Of course, you can never tell them that you can delay childbearing just because they have your oocytes frozen. That's something that's very important. It is preventive medicine, but it is not indicated. It is not indicated that they delay childbearing just for that purpose. And the third and the very important point, which all the IVF specialists will know, is there has been an explosion in the use of donor eggs for fertility treatment. And most of the reasons are, of course, 50% of the reason is medical, but most of it is age related. Women are older than 35, their own eggs are not able to give them a pregnancy for many IVF cycles, and there has been an expedition of having a baby, so they are going for donor oocytes earlier in the life cycle. The problem is economical as well as social. The economical problem is IVF cycles today. Even so, if I talk about the Indian scenario, IVF is still expensive for the average Indian population, and they cannot undergo 8 to 10 IVF cycles that we see reported in US and UK. Here they can maximum afford 3 to 4 cycles, which has been our experience in general. So what happens is they start pushing for donor eggs more than the IVF specialists. They say we want to have a baby earlier, so if our oocytes are not working, please please move ahead to gamete donation. But there is always a psychological aspect to it. They always say maybe if this option was available when we were young, we would have exercised it and we would not be facing with oocyte donation today. So that psychosocial element also has to be considered when you provide social egg freezing to women. Okay, so these are few of the committee opinions around the world regarding why they consider egg freezing can be indicated as and be used as preventive medicine in case of age-related decline. The main is ASRM, SART, which generally have been slower than ESHRE in recommending egg freezing for non-medical reasons. In 2013, they said that cryopreservation of oocytes is no longer experimental, but they did not support it for social egg freezing because they stated there's a lack of data for that specific population, meaning they wanted more RCTs for giving it for age-related decline. However, the Canadian Fertility Society, which is also pretty expansive, they in 2012 they released a statement that they are supporting women wishing to preserve their fertility against the race of time. However, in 2016, in January, ASRM came out in support of freezing for non-medical reasons for the army, for the US Army, that they said that they can go for egg freezing. And also, and this is their original press release, this is also important for those who delay family building because of other commitments. So basically, they changed their view from 2013 to 2016, and they are moving slowly towards non-medical reasons and age-related decline for social egg freezing. Okay. Preventive medicine. So what exactly comes under preventive medicine? I've talked about social egg freezing and how it can be used for non-medical reasons and why it is indicated, what are the committee opinions around the world. But when it comes to preventive medicine, we have to consider that most preventive medicine options that are given in the society are available for everybody without any subset. For example, vaccination, which is prophylaxis, which is preventive medicine. But there is no difference in who it can be given to. Everybody can be vaccinated. It's not the same with this subset of population. Yes, it can go under the era of preventive medicine, but for today, we have to be little cautionary in giving it to everybody. The specific subset is women of reproductive age who are anticipating a decline because they lack a suitable partner, or they are holding off having a baby for extenuated circumstances. Giving it to a woman or offering it to a woman so that she can delay childbirth, even though it's available to her right now, is not the right thing for her. You might be misinforming the patient that this is a better option than going for a normal regular pregnancy at her reproductive age. So that is not indicated. Of course, the age-related cost and the fecundity benefits are different for different ages. If you freeze too early, your benefits related to cost are low. If you freeze too late, your benefit of having the child is too low. So you have to give it to a particular subset from the age of 30 to 39, which is recommended by all the committees. Above, the chances of having a baby are very low, and below, the cost saving for the patient is very low. The third thing, which is very, very important, which I really want to highlight is, right now, not many centers in India are that proficient in oocyte vitrification. So the problem with this is there is a technique gap between so the technique is very well set, but there is a gap in the number of people that can perform it. So right now it is very, very important to ensure that everybody comes up to speed in the technology, and that we can properly provide it to the patients. And there needs to be a national registry where all this information can be given, so that the data of each clinic can be properly monitored by the respective authority. Actually, Dr. Rao can, or Dr. Timms can provide you more information regarding that how something like this can be done, because we want this technique to go out to the public, so that the women of India can be empowered. It is an empowerment tool, if you think about it. They are the ones who are facing the maximum pressure for doing, for taking care of the family as well as their career. And this is something that could give them a little more breathing space. But we have to do it the right way if we want to make it an option on preventive medicine. So this is my side of the talk. Thank you so much.